Ryan Stan here with ACEP Frontline, today joined by Dr. Sean Michael, and if you haven't heard of him in the past, it's a weird context. I think it was through a conference, I can't remember where it was. I was down in South Carolina, maybe, and ended up, I think one of your predecessors referred me back to you. So if you want to listen to the podcast, we were talking about behavioral health and the rights of EMTALA, and that is from July of 2024, so check that one out as well. But Dr. Sean Michael, welcome back with us here at LAC, and talking a little bit today more about boarding. So first, give us a little background, because you are one of the CMS medical directors for Region 8, I believe, and then also an emergency medicine physician as well. So just kind of give a little bit of background before we dive into things.
Yeah, thanks for the invite. I think this regional CMO role at CMS is sort of a bit of a misnomer. And as you mentioned, so we had over time 10 in each of the 10 HHS and CMS regions around the country, had one chief medical officer for each of those regions back in the historical past. We're now down to really 3 across the country. And so we think about things not really like in this geographic construct as much anymore, and really kind of topical domains. And so I get to kind of be the resident emergency physician across the CMS programs and policy areas, which is great. We do all of the other sort of work that CMS does as well across all of our areas, but particularly in things that relate to EMTALA, as when we first talked, emergency department boarding, crowding, flow through hospitals generally and out of hospitals, emergency care of older adults, behavioral health and EDs, like national security and preparedness stuff that we touch in EDs. All of those things have a lot of interest to CMS, but we don't have one place within the agency where they sit. It's similar to sort of how emergency medical services works across federal government, right? We think about, like, why is it in Department of Transportation? And there are lots of people who care about EMS. There are lots of people who care about emergency care and boarding, but we don't have as many places where there's a natural home. So I do that horizontal integration. I sort of go to all of the homes within CMS where in our programs for payment, in our programs for clinical standards, in our quality measurement programs, everyone's sort of working to advance some of these tools that we have. And I kind of do the horizontal cross-cutting, similar to sort of what we do in emergency care generally, right? We're working with lots of different specialists and sort of being the generalist.
And that's what we like here, is the conversation we've been having and what we've had in the past really has been how CMS can benefit us in emergency medicine. So especially with the EMTALA, with regard to behavioral health and straightening out SI and HI, those types of things. But today, really more about the boarding. So a huge topic that we're talking about here at LAC, it's gotten a lot of headlines, a lot of questions about how it's to best tackle it. Hopefully not, emergency medicine versus hospitals, it's working together. So give us a little background on the CMS viewpoint of boarding and some of the thoughts on where we go.
An agency that we have sort of 4 large buckets of levers, and we can kind of delve into these in more detail, but to lay it out, we've got quality measurement levers, and that's sort of topically interesting right now because of the ECAT measure that's rolling out next year. We have a whole set of levers around clinical standards. EMTALA fits into that. The conditions of participation for hospitals fit into that. We have a whole bucket of levers around payment policy. That's both payment for hospitals, that sort of changing some of the incentives and structures that sort of drive boarding in the operating system of how hospitals sort of drive their finances. But also from the hospital standpoint, it's very difficult to get, for example, post-acute care authorization. There's prior auth sort of barriers. Medicare Advantage plans have sort of increased in their market presence, and sort of that changes the dynamic for hospitals as well. So we've got a whole body of work in that area as well. There's lots of other places that we can kind of delve into, a hospital at home and other things that we can sort of do in that payment realm. And also communication and convening, right? Like just merely as an agency, people look at what CMS is talking about, what we're doing. So merely shining a light on sort of the system-wide nature of this problem, the fact that it's not a problem of emergency departments shows up in emergency departments for sure, because we're the nexus point of the ambulatory setting, the inpatient setting, the perioperative setting, long-term care setting. But messaging as a system-wide problem where we really have lots of convening opportunities as an agency, lots of opportunity to sort of talk about this and its importance, and lots of opportunity to actually do something to change some of those structures and those other buckets as well.
So this is going to be my mini mental status exam here, because I'm going to remember the 4.
All right.
So we're going to go through them one by one. And then at the end, you can judge whether I passed my mini mental status exam. So we're going to start off initially with measures. Of course, us in medicine, measures are a reality. So kind of talk about how with boarding, we can start to look at potentially some of these measures and checkpoints and things that will be held to with regard to the boarding standard?
One of the things that I would say about this, just to level set it at the beginning, is that there isn't one magical opportunity here, right? And so the measurement lever, because it tends to be timely right now, is one that a lot of people are talking about. And so I want to say with all of these buckets that they interdigitate, they reinforce each other. They have an opportunity to, any one thing has an opportunity to create unintended consequences, right? So to try to buttress against unintended consequences in one area, we want to make sure that all of these things sort of relate. And so the ECAT measure is not a standalone. It's not a, we're going to do this and then be done. But generally speaking, this is a hospital level measure, right? It says emergency in the title. But one of the things, like all hospital measures, a patient safety measure, a CODI measure, a CLABSI measure, like those are hospital-wide measures, and this one is too, is for now a pay for reporting. Eventually, there's sort of talk, we can kind of get into this in detail, about whether that could become a pay for performance measure as well, and that's been sort of in our public pre-rulemaking dialogue, and we're getting public comment on that. But right now, the idea is for 2027 voluntary reporting, for 2028 mandatory reporting, for payment determination in 2030 by hospitals. And the measure construct is sort of this idea of what would access to emergency care for a hospital look like. So there's sort of 4 elements that you have to hit to say, yep, check, you got access to emergency care. The denominator is everybody who's seeking emergency care. So it's not just one payer. There's no carve-outs for, this population doesn't count or this population counts. And it's really from the time of arrival to the time that you're in a place with audiovisual privacy enough to have a history and exam conversation, 1 hour limit to be able to say that you had access to emergency care for the purpose of the measure. You have to actually see a qualified medical personnel in order to conduct your medical screening exam the way that sort of EMTALA talks about it. In other words, if you leave without being seen and you don't actually have that exam, that doesn't count as access to emergency care, obviously. And then boarding and length of stay are the other two. So boarding, there's a 4-hour sort of time threshold, and length of stay, there's an 8-hour time threshold. Going over those on any given patient encounter counts as not meeting the measure. The idea isn't that 100% of the time, every single patient seeking emergency care will always have all 4 of those, right? I think that we understand that there's situations where length of stay sometimes is value added. There's situations where sometimes, under really extreme surge scenarios, that 1-hour time frame in some situations might not be as realistically achievable. But that is the goal, and that shouldn't stop us from setting the goal. And I also just want to point out, we can kind of delve into this in more detail, that the thresholds, the time thresholds, are sort of based on where the evidence is today, based on a technical expert panel that came together, lots of work from the measure developers and the measure stewards who sort of looked at creating this measure through the public rulemaking process and based on public comment as well. And it's not an endorsement that boarding as a general concept is okay, or that not seeing a physician when you come into an emergency department is okay, but it is, from a quality measurement standpoint, a place where you have to draw the line somewhere, and the harms seem to accumulate for boarding in particular, somewhere in the 2, 3, 4-hour range. And so that line is not a definition of when boarding starts. That line is after about 4 hours of boarding, and it trips the measure because that's where we start to see a rapid accumulation of the quality and safety issues.
And that's been a lot of things we've seen has been the challenge in actually giving a value. When they say, what is boarding? And like, well, it's really kind of up to the hospital. And you say, maybe it's 2 hours, maybe it's 4 hours, maybe it's 5 hours, maybe it's flipped, whatever. I mean, I can still remember the very first boarder I had as a resident at the University of Kentucky, and we had no idea what it was. I still remember the first one that stayed 24 hours. I still remember the first one that stayed a week in the emergency department. It's not a terribly old problem for most of us in the country. But at the same time, I mean, it's not like I'm young, middle career type stuff. But at the same time, this is something now that even in our community hospitals is starting to be a little bit more pervasive. All right, so we've hit the measure lever. Yep. Let's transition to the standards lever.
I love it. So I think the general level setting here is like the harms that happen to patients when they're boarding are not occurring out of malice, right? They're occurring because it's just a predictable consequence of the way the system is
really
designed.
Not what emergency medicine is built for,
yes,
honestly.
Exactly.
Our
design. Exactly. We're using EDs as an inpatient care setting, and it's not because somebody is being evil and twirling their mustache thinking like, how do we keep the most patients in the ED and harm them? It's really hospitals are responding to rational incentives for them as well, right? The operating system incentivizes, the economics of sort of how hospitals get paid incentivize preferentially using inpatient resources for higher margin admissions and spilling over the admissions which tend to be lower margin from the ED and allowing those patients to stay in the ED. That comes with a lot of safety and adverse quality consequences for those patients. And the clinical standards programs that CMS has in statute are basically rooted in what is necessary for the health and safety of our beneficiaries. To be a participating provider in the Medicare program, or like part of the deal, the exchange of value with the public, is if we're going to provide public funding, we have to make sure that there's a minimum health and safety standard. It's not the aspirational standard for everywhere, it's just the minimum floor. And there's sort of two buckets in there that we think are sub-buckets that we think about. One is around EMTALA, and the other is around conditions of participation. And EMTALA is technically not one of the conditions of participation, but we sort of think of it because it's separate legislation. We think of it as one of the terms that hospitals agree to. We can sort of delve into those as much as you want, but I think generally speaking, I would say that this is a place where CMS really sees boarding as a critical health and safety problem for the general public. It's obviously a preparedness problem for all of us as well when we occupy emergency department capacity, but also the actual adverse consequences to individual people and to the people who are next to them, not even boarded individually, right? But there's a spillover effect. And I think one of the things that we've seen recently is a publication by CMS, funded by CMS, a systematic review in health affairs on their open access scholar platform a couple of weeks ago that looks at the last 10 years of US-based studies that specifically address health and safety consequences of boarding specifically, not crowding generally, but the actual tactic of boarding admitted inpatients in EDs. And that itself is sort of a big step. CMS is not a grant-making organization. We don't typically go around funding lots of reviews, right? But that shows and sort of signals the seriousness with which we're looking at the health and safety angle here, because that informs sort of how we can develop standards around it.
So let's dive a little bit more into that, because you mentioned the EMTALA piece, which I think for us in emergency medicine, we are very familiar with the EMTALA piece. I think sometimes we see it from the potential punitive side of it when it's actually a tool that we can use. And that's actually the conversation we had in July, was that using it as a tool, by emergency physicians rather than as something to be afraid of. But also I don't know that a ton of physicians understand the participation side of emergency medicine and how that works. If you're accepting payments from Medicare and whatnot, of actually being the participant and the rules that come with that. So just dive a little bit into that to help our physicians understand kind of that side of CMS and the interaction with emergency medicine.
Yep, and I think that's a really good point that leads to who are we talking about here as the sort of subject of the standards. And in this context, we're talking about the hospitals, really. Mm-hmm. We could have sort of an adjacent conversation about a nursing home, for example, that participates, right? And that's from the hospital's perspective, a significant outflow obstruction. But talking about just the hospitals for a minute, in order to be part of the bargain and sort of taking Medicare patients, as in the Medicare participating provider agreement that hospitals sign, there's an agreement to sort of comply with a lot of conditions, including how the governing body has to be organized and medical staff things that we're used to sort of interacting with, and credentialing processes. And there's quality assurance and performance improvement processes that hospitals have to do. There's nursing services that hospitals have to comply with. All the sorts of things we think about healthcare as being sort of highly regulated, but all of those regulations are sort of rooted in this idea of what's the minimum necessary health and safety standard that you'd have to apply. And then accrediting organizations like the Joint Commission, DNV, we see those organizations fill a role. They are essentially contractors, or they work in an agreement with CMS to basically survey to the conditions of participation. They build their own standards, their own education programs, and support around it as part of their business, right? But those organizations look to the CMS conditions of participation to figure out what are the standards that surveyors look at, and what are the sort of minimum standards that hospitals have to accomplish to be accredited in one of those programs. If a hospital is accredited in one of those programs, then there's not a separate survey from CMS to come say, hey, do you meet all the conditions of participation? If a hospital doesn't participate in one of those programs, then usually a state on behalf of CMS goes and sort of certifies the hospital complies with all those conditions. And one of the things that is worth sort of thinking about is that in delivering inpatient care, there are a lot of conditions that a hospital agrees to deliver inpatient care. And it's obvious things like nursing care and sort of a physician overseeing their care if they're a Medicare beneficiary, for example. But also there are pieces like nutrition services and access to pharmacy services and what happens if they need imaging. So there's standards around all of those. And one of the things that boarding threatens is it allows patients to be in a situation where they're ostensibly getting inpatient care, But the care that is being delivered is not the same quality and doesn't meet the same standard that the rest of the patients sort of in the hospital proper, in an inpatient setting are getting. And the conditions have something to say about that. And there is some enforcement history with hospitals that have not met those conditions. There's also the opportunity to add new conditions of participation through sort of rulemaking and public comment processes as well if the existing conditions don't fully adequately capture the health and safety consequences.
Well, we see that a lot when when there's an issue, CMS coming in and investigating, threatening the conditions of participation. And that's, for me, that's like when the hospital's like, that's like the nuclear option. So kind of what does that mean when they say CMS is coming in and may pull the conditions of participation?
Yeah, CMS is not in the business of shutting down hospitals or causing problems, right? And I have this conversation a lot with hospital executives when we're in an enforcement cycle that we want to get out of your hair as much as you would like us to be out of your hair as well, right? And so I think working together to figure out a proactive posture for hospitals so that they remain compliant with all those conditions that are sort of part of the bargain, and educate their workforce and sort of build the systems and structures they need. That's our preference, is to proactively have everybody sort of achieving that baseline level of quality and safety. And there are situations, often these are sort of complaint-driven situations like EMTALA, but there are situations where a hospital isn't able to comply with that for some circumstance. Something happens to somebody often as the trigger for the complaint, although it doesn't actually have to have harm reach a patient to assess that the hospital is not compliant. We would like to find things before harm reaches patients. That's the whole point of organizations and accrediting bodies sort of coming and doing periodic surveys, not waiting for a complaint. But the remedy that CMS has in a legal sense is saying, well, this is sort of part of the contract, and you're not complying with the contract, so we have to threaten taking away the contract. And that's the Medicare Participating Provider Agreement, the nuclear option, as you said. And we don't want to take away Medicare funding or, by extension, Medicaid funding, because they're sort of tied together in the law. But that is the remedy that we have. And so our preference is strongly in favor of using that threat of termination, because that's what we can do, and using that opportunity to put hospitals into a plan of correction timeframe where they can change processes, they can get resurveyed, and surveyors can come back and say, yes, you fixed this, you're back in compliance, that worked. And then they can have a period of monitoring that the hospitals can do internally and that the surveyors can sort of check on to make sure that they do stay in compliance. We'd much rather have hospitals go back in compliance. And it's exceedingly rare to terminate hospitals from CMS's standpoint, but it is the only sort of opportunity that we have with the law the way that it exists right now.
Sometimes you gotta correct it.
It's the only stick. Yep.
Yeah, it happens. All right, let's talk about payment. I mean, I think we talked to a couple of state legislators, and one of my favorite quotes from Dr. Venkat was, typically politics is not red and blue, it's green, talking about the dollars, and that's huge because we understand that hospitals are running narrow margins, so much of this is driven by the government-based payers. The commercial payers follow suit. Talk a little bit about the payment side of that and where CMS is kind of boarding into that equation.
There's a few different places. So one that I would just lay out at the beginning is the idea similar to what we talked about in conditions of participation. This gets back to the idea of these all interdigitate, is that if we're paying for inpatient care, say for a Medicare beneficiary, I think CMS expects that inpatient care will be delivered with the same quality and safety that we would expect. And there's a way in the clinical standards realm to sort of suggest that, but there are opportunities in the payment realm to suggest that as well. And so I'm not saying that every instance of every patient boarding in an ED means that person is getting substandard care, but there is an interest in making sure that when we're paying for inpatient care is actually being delivered. And so there's sort of a program integrity payment lens on that as well. In addition, there are lots of other sort of programs that we have that can help make sure the economics align with smoothing hospital flow, with making sure that people can get out of the hospital. We talked about sort of prior authorization work and sort of decreasing some of those burdens, tightening up the timeframes to be able to get authorization from a Medicare Advantage plan, for example, to get somebody out of the hospital. There's lots of work around acute hospital care at home, and so many hospitals have been interested in that. It's been, from the way the legislation had worked, it's been on sort of a 1 year at a time sort of renewal cycle. We're now in a 5-year time horizon, which is actually really positive and helps hospitals sort of know how much runway they have to be able to get a program up and running if they haven't set that up already. So I think we're really excited that that's sort of one payment mechanism for hospitals. There's also, the sort of the underlying economics of all of, from a hospital standpoint, how they allocate their resources or something that's really interesting for us. It's not something that's easily changed, and this is a place where there's lots of potential unintended consequences, and we've been very deliberate about making sure that we're not introducing changes that sort of distort all of the incentives in yet a different but also wrong way compared to how they are today. But understanding that patients who have an unscheduled need for admission and really do need inpatient services, that contribution margin for hospitals for that patient's admission being vastly different than a scheduled admission, often for a procedural reason, like that difference is part of what drives a rational decision to sort of allocate resources like this. And so making sure that there's, in the economics literature, in the health research, making sure that we understand sort of like what that valuation difference means on the ground, understanding if there's a different intensity of service that's actually provided, and figuring out if there's ways over time that we can layer in other sort of payment incentives to sort of rebalance that is of interest as well.
So, I mean, what I like to hear is the fact that we're looking at opportunities with a carrot as opposed to the stick of clearing out some of the barriers that are there. In fact, that's when you started the podcast talking about, I thought this, instead of payments, was actually going to be some of the barriers, relieving a lot of those barriers, which does make a ton of sense, because that is one of the bigger issues we face, is not just getting patients in the hospital, but even more difficult sometimes getting patients out of the hospital. Yes. And so for most of us, in my hospital, we've started our own EMS agency. The big hospital down the road, they have their own EMS agency to get these folks home and get them out and get those beds available. All right, so we're down to number 4, which is our communication / messaging / education piece of that. So talk about that, because I think that's one of the most important things, because I think that's the important side of our conversations, is understanding a lot of what CMS is, and it's not the state trooper that's coming up behind you. It's more of this tool that's being used for safety standards and all of those types of things. So let's talk about some of that education, communication, and messaging.
You passed the test with the 4 buckets.
Yes, I did. Yeah. Woohoo! I made it.
So Dr. Oz likes to talk a lot about the power of convening, and sort of one of the ways to think about that is, even if CMS doesn't have a statutory lever, and right, we're an executive branch agency, we follow what the statute says, Congress gives us our authorities, we execute, right? But if we don't have a statutory lever to do any particular thing, that doesn't mean we can't talk about it, and doesn't mean we can't convene the stakeholders to be able to think through what the issues are and understand what is within our authorities, and understand where those stakeholders want to sort of voluntarily do things as well. And that's happened in a lot of spaces. It's happened in the health technology space. It's happened in sort of the prior authorization in commercial plans, right? CMS is not the master regulator of all of healthcare, even though sort of the common colloquial notion is like we can just tinker with everything across the healthcare system. Our authorities are really, rooted in particular elements of the statute, including the Medicare program. But that doesn't mean that we can't have conversations about issues that sort of span all of healthcare delivery. And so that's one of the things that we want to be out doing. We've done that at the CMS Quality Conference the last 3 years in a row. This past Quality Conference, just over a month ago, had a really great speaker from a chief quality officer who was not an emergency physician, but who sort of decided this is a big quality and safety issue for my organization and across our health system. Frankly, we're going to stop doing it. No more boarding, and here's what we're going to do to sort of change our inpatient flow, change our outflow from the hospital, change how we think about this, and change how we measure it internally, and really demonstrate sort of leadership inside a health system. And from CMS's standpoint, that's a really valuable story to tell. So we told that story from his standpoint at the quality conference, and that's an example of sort of providing positive tools and examples of sort of real-world implementations that CMS has the sort of convening ability or the platform, the communications platform, to be able to use to talk about that. Just making sure that people out in the world, emergency physicians and listeners to this podcast, making sure that they sort of understand all of the different pieces that we have moving in parallel. One of my big challenges is people want, like, what's the one thing? Tell me just the one thing you're doing. And now it's, tell me about the ECAT measure. And that is great, but it's actually really important that locally, everyone is talking within their group, their organization, their department, their hospital, their organizations, to be able to say, like, actually, CMS looks like they're moving quite a few things in parallel here. And we're going to start to see this landscape shifting. We want to be an early mover. We want to make sure that we are adopting the best practices. We want to make sure that we understand sort of where all of these things are going, and we can all kind of skate to where the puck is going. So CMS, through those communication strategies, can sort of signal that as well. I mentioned the systematic review, but we also, at the Health Affairs on their Scholar platform, which is open access, published a year-long series about a bunch of different boarding-related articles over this past year. And we had the opportunity with our colleagues at AHRQ to be able to kick off that series with sort of, here's how AHRQ, HRQ thinks about this, and here's how CMS thinks about this. And so situations that lend themselves to getting people together are great, but also publishing in the medical literature is great, and being in sort of periodicals that are read by clinicians are great, and reaching podcast audiences is great. So all of these are things that we're sort of trying to move in concert to be able to get the word out.
And that's the beauty of this thing is when we see, whether it's the FTC with some of the vertical integration, whether it's CMS now with boarding and some of the other measures, once it makes it on the radar, you know that it matters, and that's where you're like, okay, we can actually get some traction now and work towards these things. Yeah. And that's what, out of sight, out of mind, for us with ACEP, it's, with this being on the table right now with CMS, it's, all right, so let's see how we can all work together to kind of move this forward and make the best decisions that are going to benefit the physicians, the departments, and the hospitals, but most importantly, the patients, because that's the goal in the end. So how can folks get in touch with that? We got all four, all right? We got the levers that we have of the metrics that we have. We have the standards, we have the payment, and then, of course, the comms, collaboration, convening, those types of things. So pass my mini mental status exam. Talking with Dr. Sean Michael with CMS, CMO. I was going to say of the Region 8, but now we're down to 3 people. I mean, is this like Fight Club? Are you guys going to go down?
We love each other. We have a great team, and we get and I have to say,
I thought this was like an episode of Lone Survivor.
No, we would love more. I think that's actually one of the things. To your question about how do you get involved here, we as an agency, and Dr. Oz has said this, we really want more people on this bus and under this tent to really bring in their expertise, and people who are curious and people who are competent and compassionate for patients, as you said. That is really part of our strategy as an agency also, is find more people with clinical backgrounds included. And so that doesn't mean you have to come and be the 4th or the 5th or whatever regional CMO. There are lots of roles to get involved, but we do want people to be involved. And so that's one. Another is to amplify the message when you see it, right? It's really hard to get people to read the Federal Register, right? I work in the government, I don't read everything in the Federal. It's ridiculous. It's tens of thousands of pages. And so we need to find other communication channels. And so people can get involved actually by continuing to amplify the message when they do see stuff that comes from organizations, from CMS, and from elsewhere. And I also think that it's really useful to get public comment. We read every single comment by humans, not by AI. And there's a lot of places where each of these levers we talked about have a public comment period. And most of our notice and comment rulemaking has a period of time for people to be able to say, yes, I think that's a great idea, but did you think about these 2 elements? Or no, think about this, you could be gamed this way, or an unintended consequence might be that. Or yes, and here's a natural outgrowth of what you just said. If you, in addition, you did this other thing here, it would prevent this other foreseeable consequence. That expertise, we want to tap into that. And getting those types of feedback when we are working on advancing some of those other levers, that's actually really, really helpful and really important. It's one of the roles that organizations like ACEP play, but individuals and state chapters and other organizations can sort of play a very important role in that as well.
Yeah, and ACEP does coordinate a lot of comments in there, also working sometimes with getting the public comments involved as well. How can people either get in touch with you or find more information about this project that's going on now?
Well, I think that we don't yet have a single source of all of the CMS boarding-related stuff in one place. If that's of interest, I would love to hear from people that's of interest, because that would be helpful in sort of advancing our communication strategy. People are welcome to email me as well, and we'll make sure that my email is in the show notes, but it's sean.michael@cms.hhs.gov. And I'm really happy to sort of meet with folks and help coordinate, particularly if somebody has individual focused feedback about what they're seeing locally, or ideas about things we're not thinking have, like happy to plug people in within the places within the agency that are working on that as well, because it's a lot of different people working together. And a lot of what I get to do is help make sure that we're sort of working in the same direction and incorporating really that very valuable clinical stakeholder feedback as well.
Well, I appreciate it. Thanks for your time. Thanks for coming to the conference. You spoke earlier on one of the panels, and appreciate you joining us again here on the podcast. Again, if you haven't heard the other podcast, it's July of 2024, where we talk about EMTALA and behavioral health. And then, of course, this one here, hopefully you have more opportunities moving forward, and appreciate CMS and everybody, your leadership, supporting you being here and being with us today. So thank you so much.
Really appreciate it. Thank you, Ryan.
All right, as for me, you can contact me, rstan@acep.org, rstan@acep.org. Also invite you to like us on whatever your favorite podcast player is. Leave us a 5-star rating. Give us feedback, whatever you'd like to see, but 5 stars is very important. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.